Good morning, everybody. Thank you, as always, for joining with us today. And as far as our regular COVID numbers, again, things continue to improve. So we have no new updates today. We will periodically give you updates on our COVID numbers just to check in on that. But things have been improving slowly, and the numbers in the hospital have improved as well, at least in regards to COVID. We have been super busy, though. I wanted to briefly share, so as my role as the executive committee for SHC representative from the Department of Medicine, this past week at the faculty meeting, I shared some slides that I'd like to share again really briefly because I did share those, so I apologize for those of you who are seeing this again. The meeting, as you know, is chaired by our Chief of Staff, Dr. Megan Mahoney, who is also hanging with us today as one of our panelists and usually with us as well, helping to answer questions and join in on discussions whenever she'd like. So thank you for being with us, Dr. Mahoney, and for your leadership. Also, other members of our department, like Dr. Ann Weinecker, who's also with us today as a panelist as well. She's the Associate Chief Medical Officer along with many other roles in the Department of Medicine. So thank you for being with us. I wanted to briefly share just some slides from this recent meeting. We meet every Wednesday, first Wednesday of the month as well, with various leaders throughout the whole many schools, the many departments, as well as the SHC. As you know, Stanford Healthcare has been once again one of the top ranked best hospitals by US News and World Reports. Along those same lines, the metrics of likely to recommend have been really excellent over the target goals of 80%, from the cancer clinics to our specialty care, primary care overall, as well as UHA. I know a lot of people from UHA are here today as well. So that's really a wonderful job everybody's been doing. It was a big thing that was emphasized. Our door to balloon time, so someone comes in needing an angiocath, particularly from cardiology, the goal is typically at 90 minutes, and we've consistently been well below that, averaging at or below 60 minutes. So that's been another huge success by our cardiology folks. The Resident Safety Council projects, a lot of quality improvement projects that a lot of our faculty, such as Dr. Lisa Shea, is involved with, Dr. Weinecker, Dr. Heidenreich, a lot of great things going on, including improving Volt communication. Those of you who use Volt in the hospital have already seen the upgrades, and it's definitely improving dramatically, improving code status, ordering sepsis readmissions, as well as others that are more involved in other departments as well. And lastly, just want to emphasize vaccination requirements have been in effect. You've heard Dr. Bowman talk about that regularly. We've had a really good high percentage of our faculty and staff be vaccinated, which is excellent to see. I also want to put a shout out for our next town hall by Dr. Mahoney. Will be December 2nd at 5 p.m. We'll send more information about that when the date gets closer. And congratulations to our own Dr. Jason Harm, who is the new Health Information Manager Committee Chair that starts effective now. So thanks to everybody. I just want to lastly say, for those of you who do have any information that you want shared or anything you want me to take back to the HSC committee, that's my role. So please feel comfortable reaching out anytime. With that being said, I'm excited for our main speaker today, Dr. Duma. So I want to transition over and turn over the mic to Dr. Harmon, who's going to say a few things, and then also Dr. Salas as well. So Dr. Harmon, I'll turn over to you.
Thanks so much, Errol. Well, I wanted to highlight some articles that are coming out for our last week of Women in Medicine Month. It's truly been remarkable seeing faculty, postdocs, trainees, APPs, staff all featured, and to hear their voices. This week, you'll see in the newsletter kind of a takeover by Dr. Joy Wu with a piece on the impact of the pandemic on gender inequities. And Dr. Zoe Ekezie will be taking over our Twitter account, our social media account this week. She is Chief Fellow in Gastroenterology and Hepatology. Next slide. This was last week's Women in Medicine photo. I just wanted to give you a peek at these, and these are all downloadable on our Women in Medicine website through the department. And we had it on good authority that we could do a quick mask off photo from our ID faculty who joined us for the Women in Medicine photo. Next slide. I wanted to give a special thanks to this group who had worked on planning for the Women in Medicine Month, and a special shout out to Lindsay Baker, our communications program manager, who has been behind the scenes with all the communications, the content, access on our website, creating that new website for us. And so again, special thanks to this group. Next slide. Lastly, I wanted to announce the next upcoming grand rounds in celebration of Hispanic Heritage Month. And next week will be Dr. Bonnie Maldonado from our own School of Medicine here. And then on the 13th, Dr. Benicio de Jesus Perez from our Department of Medicine, the Division of Pulmonary Allergy and Critical Care Medicine. And with that, I'd like to pass the baton to Dr. Arga Gonzalez, our Special Advisor for DEI Programs, to introduce our speaker.
Thanks so much, Dr. Harmon and Dr. Zalga. It is really an honor and privilege to introduce you all to someone I have admired for a long time, Dr. Narjust Duma. Dr. Duma is a thoracic medical oncologist and the Associate Director of the Cancer Care Equity Program at the Dana-Farber Cancer Institute, having completed her residency at Rutgers and her fellowship at the Mayo Clinic in Rochester. After a year as the chief fellow, she moved on to the University of Wisconsin, where she founded her lab focusing on cancer health disparities, as well as gender and racial discrimination. There, she was also the co-director of the Internal Medicine Residency Program's Diversity Program, and she developed an innovative multidisciplinary clinic dedicated to supporting women with lung cancer. Dr. Duma fights for equity in her clinical work, on social media, and in classrooms. For example, Dr. Duma's clinical interest is lung cancer, and she is the principal investigator of the Sexual Harassment Assessment in Women with Lung Cancer, or SHAL study. On Twitter, she is the founder of #Latinas in Medicine, which brings together a community of over 6,500 global members. I hope you'll follow her on Twitter and catch a glimpse of the amazing work she's doing there. This is in addition to her curricular work to incorporate health equity into medical training. Not surprisingly, Dr. Duma has won numerous awards, far too many for me to recount for you today, but I wanted to highlight just a few. The Resident of the Year Award from the National Hispanic Medical Association, the Mayo Brothers Distinguished Fellowship Award, and the ASCO Endowed Merit Award, and a Young Investigator Award. She's a sought-after speaker across national and international stages and Zooms, and her work has been highlighted in prestigious outlets, including the New York Times. We are so grateful Dr. Duma could join us today. Please welcome Dr. Duma.
Thank you, everyone. It is a true pleasure to be here. I'm gonna talk to you two different tales, and I'm also jumping a little bit into the wagon, not only of women in medicine, but also Hispanic Heritage Month. I'm a proud Latina, and we're gonna talk about my gente, of my people. So I'm gonna share the screen. There are some videos embedded in the screen. So when the videos come, you can turn up the volume on your computer. That may help a little bit. That's what we found it will help so far. So can we all see the screen?
Great.
Yep.
So these are my disclosures, and I think it's very important to discuss them as well. So I'm going to start with a little exercise. First, I'm going to say a few words, and I want you to let your imagination just go wild. Let's do this exercise together. So let's imagine Los Angeles new mayor. A couple eating at a restaurant. A community leader. And a religious ceremony. You don't have to raise your hand or shout out your answer, but I want you to, answer yourself. How many of you imagine that new Los Angeles new mayor to be a Latino woman? And about that couple eating at the restaurant, how many of you imagine a same-sex couple? And for that community leader, how many of you imagine a middle-aged white woman? And finally, for the religious ceremony, how many of you imagine something out of Christianity? So this exercise shows that we have certain stereotypes that have been secondary to the exposures to media and education. We're going to talk about two things. The first tale I'm going to tell you is Latinx cancer care. It is time for action. So cancer is the leading cause of death among Latinos, Latinx, or Hispanics, accounting for 22% of the deaths. We can see on the right side of this figure that lung in male is the #1 cause of death, and breast in females. And a study that we conducted in a large database over 400,000 Hispanic patients, we staged for non-small cell lung cancer. One of the disparities that we observed is that only 2.2% of these patients with metastatic lung cancer that self-identify as Latinx or Hispanic receive referral to palliative care. Cancer health disparities in the Latinx population have been described in incidence, stage, mortality, survivorship, screening rates, access to clinical trial. My Gente has disparities in all aspects of cancer care and are emerging more and more that continue to be documented. One of the challenges with studying the Latinx population is that we are a very heterogeneous group, and I often use myself as an example. So my name is not commonly a Latin name. I have a grandparent that comes from pretty much every continent, and I'm grouped in these Latinx Hispanics, and we have Afro-Latinos, for example. So it can be very challenging to study a group that's so heterogeneous. Also, the beliefs and perception of health change based on the country and the geographic location. I grew up in Venezuela, down south, in Latin America, and for example, my grandma lives in the Dominican. The healthcare beliefs, even if we speak the same language, are quite different. And the problem is that we all get grouped together in this Hispanic group, despite being very different. In addition, the migration patterns in the US are different for Latinx populations. Venezuelans and Cubans migrated to Florida. We have a high number of Puerto Ricans and Dominicans in New York. In California, for example, there's a higher number of Central American patients. One of the big challenges we account for is the data. We have poor data when we're trying to understand Hispanic or Latinx cancer. We often have missing, inadequate data, oversimplifying data. For example, patients are classified as Latinx if they have a Spanish last name. Well, we have patients that are Filipino that may have a Spanish last name. And the whole controversial between ethnicity for Filipinos versus race is not the point of this talk, but that's an example. And also people acquire last names by marriage. So we have poor quality data. And this commentary on ethnicity and disease, we share some of the future directions that we recommend when collecting data about the Latinx population. Through the years, we continue to study cancer care in the Latinx population. In this paper that was published last year, we try to understand something that has been described in the Hispanic population known as fatalism, in which when patients are diagnosed with cancer, they may decide to refuse treatment or cancer-directed therapy. With the incorporation of immunotherapy to cancer treatment, to lung cancer, we have seen survivals that we never thought we would see. So we conducted this study to understand what were the reasons our patients were refusing treatment for non-small cell lung cancer in a sample of around 473,000 patients from different parts of the country. The hypothesis is that Hispanic patients and African American patients were more likely to refuse therapy. But in fact, what we discovered is that actually the patients that didn't have insurance, or the patients that have poor insurance or were underinsured, they were more likely to refuse therapy. This was followed by a focus group, and we realized that the #1 concern of these patients with stage 4 non-small cell lung cancer was the fear of leaving a big bill to their families, not dying sooner of the cancer, but increasing the financial toxicity of their families. So the social determinants of health, including access to healthcare, copay, and the financial capacity, is what was linked to the treatment refusal for some of these patients. And some of the patients that we interview, in fact, have target mutations for which we have documented years of survival now. But what can work in the Hispanic population? Well, new data for the American Cancer Society showed that the Hispanic Latinx population in the US has the highest percentage of health insurance of any other racial ethnic minority group. That was not the case. Hispanics used to be the most uninsured groups in certain areas. And this paper was just published last week. But what make a difference here? What intervention really helped? Well, the group that benefited the most for the Affordable Care Act were the Hispanics and Latinx, including the market, the open market, in which patients could have a choice in insurance. So there are interventions that work. And instead of us trying to continue to document disparities, it's time to take action and create systems in which these patients will have access to care, and they will be able to get the care instead of being worried about leaving these big bills for their families and dying probably years sooner than they could have with therapy. Another challenge, and this is a paper that published in 2018, is that we are actually doing worse when recruiting patients from minorities, women, and the elderly into clinical trials in oncology. We're not doing better, we're doing worse. There is some recent paper that shows that we went from 5% to 6.3% as general in recruitment of patients into clinical trials in oncology. But our own study showed that over time, the number of enrollees into clinical trials that are part of minority groups continues to go down, including for diseases that are more prevalent in minorities like African Americans or Black, like multiple myeloma. In many cases, a clinical trial is the best treatment option for a patient. So if we are not enrolling them in clinical trial, we're taking those options away from them. So what can we do? Because we have to talk about solutions too. What can we do to improve the recruitment of these populations, like mi gente, into clinical trials? Well, we have to change the inclusion and exclusion criteria, and we are working with the Friends in Cancer Research to improve this. Sometimes the inclusion criteria comes from the phase 1 trial and is copy-paste to the phase 2, to the phase 3, and a lot of these exclusion criteria has no base data to exist. Hispanics are most likely to have diabetes, for example, and consequence of cardiovascular diseases. Having target accruals to be mandatory by the FDA and mandatory for journals to publish. It would be important to do this. And also improve cost and coverage barriers. Most of the clinical trials are in ivory towers, like the ivory tower I am. We are not going to our patients. We're asking patients with very limited resources to pay $24 for parking to be part of a clinical trial. We need to take the clinical trials to the community hospitals. We need to make sure we go to the patients. We're asking them to be part of research, but we're also asking them to increase their expenditure and time off work. And many of these patients don't have the privilege of taking time off work. And the most important is there's physician bias. We found that if a physician knows that the patient English is not first language, or they have a challenge with English, they're significantly less likely to offer a clinical trial. How should a language be an obstruction to be participated in a trial that could be the best treatment option for that patient? Also, translated consents has become like an afterthought for many clinical trials and for budgets. Oh, we translate the consent, but when the dollars come to an end, usually it was never translated. Physician bias is real, and we need to take responsibility for this. Hispanics or Latinx patients are often labeled as poor compliance or lack of understanding. But I have seen in which un poquito de español has been used to explain why metformin is important for treatment. Try to imagine somebody who's trying to explain to you a treatment with 5 words in your language. Would you consider that treatment important? Un poquito de español is not enough to discuss nothing medical. You need to get interpreters into the room to improve the communication. And yes, we can use Julie, the patient's 10-year-old granddaughter, but that is not correct. You're putting pressure on that kid. The information may not be completely translated to grandma either. So un poquito de español is not enough. We need to make sure we use our interpreter services. There is a challenge with mistrust, and it's a challenge that has historical events. Mistrust into the healthcare system for people of color didn't come out of the blue. It comes out of many events over and over again that continue to remind you the healthcare system wasn't designed for you. I'm myself a patient, and 4 weeks ago, I was in NGH getting surgery. I can tell you there were events and situations in which I was, this is not right, despite having the privilege of being a physician in a hospital I work in. So the mistrust is real because there are events that remind us over and over again. One of those are the treatment at the immigration detention facilities, the children that were held there, the families, the death secondary to influenza and COVID-19, and reports of detainees that were getting hysterectomies without appropriate consent. How do we trust a system that continues to fail you? So we don't have to see this mistrust as, oh, they just don't trust me. No, there is historical events. There are reasons why these populations don't trust us. So we as doctors need to make sure we develop the relationship, not only with the patient, but with the family and with the community. When my great-grandpa was a doctor back in Spain, he was the doctor of the town. And people would trust him with everything. But he had a relationship with the community. So we need to come down for this ivory tower, and we need to get to know our patients. Know their blood pressure levels, but to get to know them so we can develop a trust relationship. But it won't happen overnight. This is work for years. And most importantly, we need to stop doing the phenomenon in which we come, we investigate, we get our responses, and leave the community. Diversifying the workforce. Data has shown that patients that have healthcare providers that have similar background do better. But right now, for example, Latinas are 1.8% of the physicians in the US. We don't have enough doctors today to treat all minority patients. So we have to diversify the workforce, not only at the physician level, but all research and clinical personnel. Personnel that's bilingual, diverse, and is culturally aware, not culturally competent, culturally aware of the differences that exist in we Hispanics and the difference that exists with any other cultures or diverse populations. As I said before, we need to stop this researcher role in which we are, hi, can you answer this questionnaire? And you will never see me again. As a Latina medical student, I remember getting so many questionnaires about, we want to document your experience. And I never know what happened at the end. I did answer the survey. When you're asking, you need to give something back. Because many of the people that we work with you, many of these populations that you're trying to study, they're taking their time, very limited time to work with you. So let's stop doing this migration researcher in which we come and we leave and we never come back. Develop relationships to improve the mistrust that has followed our relationships with these populations for 500 years, probably more. So we talk about Hispanic cancer care. That's the first tale. We continue to fail our Hispanic patients with cancer. There are disparities at the time of diagnosis. They're less likely to undergo mammograms. They're less likely to get lung cancer screening. For example, for lung cancer, if you're a woman of color, you're 6 times less likely to be referred for lung cancer screening despite meeting the eligibility criteria. Hispanics and Latinx are less likely to be included in clinical trials. They're less likely to get access to targeted therapy specific to their cancer, and they're significantly less likely to meet with palliative care or be referred to hospice. A recent study presented at ASCO 2021 showed that patients that are Medicaid, Hispanics or Blacks, were dying at home without hospice referral since COVID times started. So even at the time of death, we continue to fail all these vulnerable populations without referrals to hospice, without appropriate palliative care. So the first tell to you is that we continue and we need to work in Hispanic Latinx cancer care. It is the ethical thing to do. So as a segue into the diversity workforce, I'm going to tell you the other tale. And the other tale is a personal tale for me. I strongly believe in the power of storytelling. I can come to you today, show you a very nice Kaplan-Meier curve, and you probably will remember it tomorrow. In oncology, it's very hard to do a presentation without those graphs. But I'm going to tell you my own story so you can learn from it and hopefully help your students, trainees, colleagues, and neighbors. So this is me as a second-year resident in New Jersey. And I have a privileged background. I come from a fourth-generation physician household. My mother was a single general surgeon that trained in the 80s. So being rough and tough is what we know in my house. When I came to this country, I came to do my medical school rotations. Immediately landed and I was a stereotype. I was spicy, loud, and I remember being in residency, and despite all efforts, I would be getting comments like, "Oh, you are so Latina." And today I still don't know what "you are so Latina" means. And a lot of coming from the Dominican Republic, your outfits are colorful because you don't wear black in the Dominican. It is a very bad idea. It's just hot. But I remember having comments about my outfits, having comments about my hair. "Oh, you look so good when your hair is straight." And that made me feel like I didn't belong in medicine. And that's extremely hard for me because I was raised by PACU nurses. My mother, as a single mother, used to leave me in the PACU because you always don't get childcare when she would go to the OR. Of course, I think that's kind of illegal now, but I guess in the early 90s it was okay. All those comments in this environment that remind me over and over again that I didn't belong put me in clinical depression. The ironic part of all of this is that despite being trying to be put in a box, tell multiple times that my earrings were not professional, that my clothes was too colorful, and how professionalism was used against me and my colleagues that come from a different background. On my class of 52, we were 2 Latinas. So I continued to do research in that time and won awards and big presentations. And people would call me a rising star. But they didn't know I was clinically depressed and I would cry from the parking lot of the hospital all the way to my house. And if you live in Jersey and you take the New Jersey Turnpike, that's quite some time. And it was secondary to the sense that I didn't belong in medicine. Despite coming from this background, despite knowing that the hospital felt like home most of the time. I remember putting my white coat and seeing that it was like a little costume in which I would prevent myself for sharing my experiences with my colleagues because we didn't share the same experiences. So I would hide key parts of my personality in order to try to fit in. I remember being told I should man up. One day I was found crying in the bathroom, and I was told several times I should be more like somebody else who was not my similar background. But one day I remember being in fellowship. I was just exhausted, trying to hide key pieces of my personality. To the program directors, to all the leadership, I was doing great. I won all the awards and all the pieces of glass. But I felt like my white coat didn't fit. I felt like I didn't have a place in medicine. And walking in the hallways of the medical school didn't help. Nobody looked like me in those pictures. Eventually, I remember waking up and realizing that this is what it needed to be. It needed to be Narjust from Venezuela, and I couldn't be anybody else. But there was a lot of years of struggle. And I remember putting this same yellow dress I'm wearing here with you today. And I remember putting down my hair, because I had my hair down for around 3 years in residency, because curly hair was not found to be professional enough for medicine. Or I was told multiple times that it's better when you have it up. And I remember also putting a pair of hoops that now I don't take off, because hoops have a historical background for populations of color. And who told me hoops cannot be professional? Now I'm giving a ground talks presentation, ground rounds to you, and I just put my hoops on. My story is actually not strange, it's very common. So I have several people that are gonna share these stories with you. So please turn up that volume so you can hear them.
You're from the Caribbean? You're so well spoken. I bet you'll get the job because you're a woman and you're black. Oh, your hair looks so nice when it's straight. It's so professional. Calm down. You're making me uncomfortable. No offense, but you're just not the right fit. We don't have a job for you. These are just some of the microaggressions that I have experienced over the last several years. From colleagues, from friends, from patients, from leaders. These are the things that, when you think about them being internalized, lead to feeling like you do not belong.
Before I had the vocabulary to describe microaggressions, I remember experiencing some very uncomfortable interactions, sometimes in the form of comments, questions, maybe innocent jokes or remarks. For example, I remember very clearly being told, "Wow, your English is really good," or "You're not Mexican," or "You're not one of those immigrants," or "You're gonna get accepted because you're a minority." And while sometimes I can brush these comments off or maybe make some positive remarks, most times these comments linger. They fester and make me question my identity, my capability, and my sense of belonging. And while the perpetrator's intention was perhaps never to hurt me, the reality is that the sexist, racist, and xenophobic comments really get me at my core and when I'm at my lowest. My name is Andrea Niño. I'm a second-year medical student, and this is what microaggressions mean to me.
Hello, I'm Ana Velasquez Mañana. I'm a medical oncology fellow at UCSF, and I am a Latina in medicine, proud Puerto Rican. I think that microaggressions for me are actions or commentaries that people make trying to give a negative impact to our culture or some part of our identity, whether it's race, gender, sexual preferences, color of your skin. Sometimes those are subtle, but sometimes they're very intentional, and people try to make them seem like a joke or commentary that goes under the rug, but really can hurt our feelings or put you down in terms of not fitting in and feeling like you're not part of a larger group. An example is something that a prior person of authority to me used to say, in which he would imply that my husband was scared of me because I was going to go all crazy Latina on him, which, as they were telling it, would say it laughing and as a joke, but really had a lot of other connotations behind it, and was something that didn't settle well and obviously did not make me feel well. Thanks.
Hi, I'm Ivy Franco. I'm a fourth-year radiation oncology resident, and microaggressions to me are comments or behaviors or events that occur multiple times a day that show implicit bias based on the way I look or what I'm expected to look like or what I'm expected to be or do. So one example is that when I was applying to medical school, I was sitting at a Starbucks working on secondary applications, and an older white male came up to me and said, "What are you doing?" And I said, "Oh, I'm working on secondary applications to medical school." And he thought that was interesting, and he said, "Where are you applying?" And I said, "Stanford and Harvard." And he looked at me, and then he said, "Well, isn't that ambitious?" And I thought, that's interesting. How would he get that from just looking at me? He doesn't know my test scores. He doesn't know my grades. And so having those events happen over and over make you really question your place in medicine, your abilities as a physician, working in a field like radiation oncology, where it's mostly white males that are attendings and residents. There's been multiple times where I've been talking to a patient for 30-40 minutes, and I go out, I bring the attending in, and they say, "Great, the doctor's finally here," even though I've been sitting with them for 40 minutes getting a history and physical. I have my white coat on, I have a badge that says doctor. They don't think that I'm the doctor because I don't look like the typical doctor. There's been times when they say, "Well, where are you from?" And I say California, and they say, "Where are you really from?" Or they'll say, "Well, where did you go to college?" And if they don't like that answer, they'll say, "Where did you go to medical school?" And so feeling like I have to justify or show them what my credentials are for them to believe that I'm a physician. Sometimes when I say I'm from Mexico, they'll say, "Well, you don't look like a Mexican." And I always say, "Well, what does a Mexican look like?" And so it's those kinds of interactions that have this bias undertone where, sometimes knowing or unknowingly people judge you based on the way you look, based on the way you sound, based on what stereotypes of a physician should look like. And so I think it's really important to be able to address those types of biases so that people understand that, yes, I'm Latina, yes, I'm Mexican, and yes, I'm a physician.
And I have to take a minute to share that we do not share the same experiences. And this is important at the current time. We have seen the news about, and my heart goes to the family of this young lady. And it's really sorry to what happened to her. But we don't share the same experiences. There's 710 indigenous people, mostly women, that have been missing in Wyoming over the last decade. We are missing our indigenous women. They are getting murdered, they're missing, but we don't hear in the news as much. So we don't share the same experiences. We do share the same ground, but it's not the same. As a result of these interactions, we founded the Latinas in Medicine group. The Latinas in Medicine group is a Twitter community of 6,500 members now. It has been an opportunity to amplify their achievements. We have developed a mentorship program, and we also have these mini interviews to highlight the accomplishments of many Latinas, and most importantly, to work as role models for the next generation of Latinas in medicine in all areas of healthcare. In addition, last year, with the help of Dr. Rodriguez, we came to ASCO and explained that, unfortunately, the representations of Latina in oncology is less than 0.5%. So we were able to do grant funding to collect enough money to fund the first Latinas in Medicine Young Investigator Award. This award was given to a Latina conducting research in breast cancer to increase sensitivity of breast tissue to radiation, particularly to Latinas. In addition, we founded the Duma Lab with the goal of creating a safe space for women of color. And here you can see one of your beautiful fellows, Dr. Patel, who's part of the lab. Because we have to create an environment to nourish the next generation of women of color in medicine. We cannot recruit them and then leave them on their own. Because that happened to me. I was recruited, and then the healthcare system did not change, or the environment did not change, so that prone to all these microaggressions and the sense of not belonging. And then we're wondering, why are Latinas leaving academia? Would you stay in a place in which you are mistreated and underappreciated, underpaid, have to deal with microaggressions every day, and you are not promoted equally? Probably not. In addition, the Duma Lab 2 months ago has a collaboration with Medscape to have a bi-weekly column, and I invite all of you to look at the column. We are talking, and we are going to continue to be talking about the unique issues for women, women of color, and person of color in academic medicine. So we are, yes, diversity is beautiful, but we continue to lack inclusion. So just like, why are people of color leaving academia? The parental penalty that many women and men experience. I'm not here to make you comfortable. These videos was not for me to praise you, but I'm here to help you become an active ally. And the last 5 minutes of this presentation is for that. So how do you become an active ally? First, doing a module doesn't make you an active ally. To be an active ally, action needs to take place. And yes, retweeting something will help amplify the message. But I'm asking all of you and everybody who's listening to this presentation to take action to make sure we create an inclusive environment for all, not only Latinos in medicine, but any underrepresented group in medicine. I have 2 more videos of 2 colleagues that has been allies during my career. You may know some of them for social media, but here are a few tips for them.
So what exactly does it mean to be an ally in medicine? To me, it starts by admitting none of us are perfect, and that we all have our biases. Each day, I learn what mine are, and each day, I learn how to mitigate them. And I think that's critical. See, self-reflection means asking yourself, how can I do better? But it also means going beyond that. It means not being afraid to speak up when something doesn't sit right. And it means proactively treating everyone equally, no matter race, sexual orientation, or gender. Finally, it means being a voice for equity in your division, department, and institution. Chris Gardner is credited as saying, strong people stand up for themselves. Stronger people, they stand up for others.
We're all familiar with the data surrounding the social determinants of health. They affect our patients' ability to afford, access, and receive care, and they lead to inferior outcomes if ignored. Similarly, there are social determinants to career success, and failing to recognize, confront, and improve the existing biases in our workplace is a missed opportunity. Our colleagues can feel at a minimum isolated and alone, and at a grim maximum threatened, unwelcome at work, and subsequently leave the field. It takes thought and effort to be an ally, but it is rewarding to see the impact of acknowledging, amplifying, and supporting your colleagues. Because equity is not a zero-sum game. It is not giving something up to have someone else succeed. And giving people an added voice from whatever position you hold helps your colleagues feel valued and helps mitigate burnout. Being an ally for equity helps you too. I've learned so much that I was previously unaware of in my own workplace, and I think that awareness has made me a better colleague, a better fellowship director, and ultimately, a better doctor.
So as we come to the end, a few tips is call out manos. These are panels that are only men. Bring other people to the table. Chenoa, what can we do next? Advocate and stop microaggressions. Be aware of pronouns. These are extremely important. Please use diverse pictures. I remember having a rash and going to the dermatology book. Didn't find anybody with my skin color back in 2004. And also, be an active ally. I'm sorry, but you interrupted Dr. Perez. Active allies sponsor, mentor, advocate, and take action. This is my final request to all of you. We all have privilege. So we can use our privilege to create equity in the clinic, in the classroom, and at the supermarket. I'm very thankful for your time. I'm going to stop sharing my screen and we can go to the Q&A section.
Thank you so much, Dr. Duma. That was an amazing talk. I loved all the videos and I mean, so many, I wrote writing furiously throughout this whole talk, different quotes, which I'll hope to share on social media after this. One thing I wanted to ask just to get us started in this Q&A is, in California, we have a large number of people who identify as Hispanic or Latinx or Latine, whichever term people want to use. Actually, it's about 40% of the population here. Acknowledging, of course, as you said, that this is a large umbrella category with lots of heterogeneity within it. That said, only about 5% of physicians in California are Latinx. What is one thing that you think any of us who are on this call today could do to change that number? We need better representation. We need more access for people who identify as any of those groups that I mentioned to get into medicine. So do you have one piece of advice or one recommended action that we all could take?
I would ask you to answer that email, because many of you may have received an email from an undergrad, a pre-med. Answer that email. That's a small action. Meet with them, even if it's once, even if you don't have the bandwidth, because rejection is associated with less likely of application. So answer that email. That's a small request. And if you haven't received an email and you know somebody, acknowledge them. That's so important, because many of us are trying to find a place in this big umbrella. And it can come a long way. Many of my mentees started with a cold email, and I met 2 of them in person for the first time this weekend after 2 years of mentorship.
Wow. Yeah, I think that's a great point. That's something we all can do. And actually that reminds me of another thing I wanted to ask you. You mentioned about allies, that allies should sponsor and mentor. You mentioned other things, but just for people on the call here, I don't know if everyone's familiar with what sponsorship is. Would you mind just giving a little definition there?
So sponsorship and mentorship are different. Sponsor just when you put your reputation at risk when recommending somebody to give a talk. You are saying, oh, I cannot do this. Dr. Riano can do it. Dr. Franco is going to do it. So instead of just guiding them, you're giving the opportunities and you're putting something at risk of your own when you do this. And Latinas are under mentor and under sponsor, but it is important that we open the doors for them and we leave them open. There are no heat with the doors coming back to close.
Yeah, absolutely. Thank you for that. And next, I want to go to Dr. Harmon, who has a question.
Thanks, Dr. Salas. Dr. Duma, that was wonderful. I'm taking many screenshots and I'm looking forward to actually having the recording as well to go back through it. You know, I'm a palliative care doctor, and I was really struck by some of the data you shared around the low rates of referrals that we've been familiar with in the field. We know that this is a problem. Our palliative care group is working with a local organization called Latinas Contra Cancer. And I was curious, you know, we've been trying to think about strategies around increasing those referrals, and wondering what you've seen kind of at the top of the list in terms of getting more referrals, more timely referrals from what you were describing for palliative care and then hospice, particularly as the pandemic continues for us.
So I have 2 recommendations. One is like, let's just make it, you know, when you're in service, if you don't document the DVT prophylaxis for the patient, you like no close the encounter, or you can no bill. We need to make that as palliative care for patients with metastatic lung cancer or metastatic cancer, period. Like PPI prophylaxis, right? That's automatic in our brain. Like I remember my residency, no note could be signed without that. Why can't we do the same about palliative care, right? These people are dying in pain. You know that a patient with metastatic lung cancer that's dying at home without hospice is probably under-medicated. So I would do that. And the second thing is we need to communicate in several languages, not only Spanish, the difference between palliative care and hospice, because that difference is still very blurry for everyone. but I think we have to go to the community. I think we keep putting science in the hospitals. We need to go and talk to grandma, because grandmas are very important in the Latinx community, and it's very family-centered programs. So I always go to the grandmas. Like, I was in a community here called Lawrence this weekend, and they're like, who do you want to meet with? The grandmas. We are meet with the youth later, but let's meet with the people in power.
Thank you.
Yeah, I love that. Let's meet with the grandma. Next up, and by the way, I want to acknowledge we have a number of questions in the Q&A. We probably won't get to all of them, but I want to go to Dr. Mahoney, and then I'll try to address one of the ones that's been upvoted in the Q&A. Dr. Mahoney.
Oh, thank you. And thank you, Dr. Duma, for an incredible talk, effective use of storytelling. I loved hearing from all of the other women who expressed themselves. It was just really lovely to see that. I had a specific question about the health equity data that you presented and how poor communication can be a factor. And I especially, I was writing down quotes too, like the un poquito español is not enough. And I just am wondering if you have any suggestions or ideas for us and how to address two concerns that I think we have seen. We do have a policy on the requirement of engaging a qualified bilingual interpreter for interactions with patients whenever there's technical or medical information that's being conveyed. I don't know about the uptake of that, if there are, like you were pointing out, interactions where, you know, we're not engaging an interpreter. And then I don't know how effective we are in ensuring that everybody is either assessing whether or not they are a qualified interpreter, or if they're just trying their best and not realizing that we do have, you know, an assessment. You can get a gift card if you go through it. But do you have any recommendations for us as an organization to improve the engagement of the services that are available to ensure that adequate communication and effective communication is happening with our patients?
I think one of the things is to start early, like make it a costume, right? Because we learn from role modeling. So medical students should, now we don't have CS, so during the OSCEs, are they trained to work via interpreter? I didn't get any training on how to work with an interpreter. I graduated medical school, graduated first of my class, still, interpreter, how do I do that? We need to teach them. So we're asking them to do something without providing any guidance. It's like, go and ride the bike. Good luck, right? So provide guidance to residents. And for the attendants, they should be motivated to be the role model to say, no, I'm not doing this with a very limited language. We're getting the interpreter. And now with the iPads, like with these iPads, it is great. Yes, it takes double time. But I always try, so this is what I do with rounding before the first day of rounds. I sit them down and all of a sudden I start speaking Spanish to them. And I end and I say, that's what we're gonna discuss tomorrow after rounds. And you can see the students and the residents and the fellows like, what's going on with this woman? So I am saying, this is how it feels when you try to discuss with a patient that doesn't speak English, a treatment pattern. And honestly, it has worked so far. I have seen the most common funny faces when I do that. It's like, why is this lady speaking Spanish for 5 minutes non-stop? And I'm like, how do you feel about that? And she's like, well, I felt excluded. I felt like I didn't know what to do. So now imagine it's about your health and not an assignment for tomorrow. And that has helped. Everybody laughs at the end. At the beginning, they're all afraid, but they laugh at the end. So that's a little trick that I've been using for the last 3 years.
Excellent. Thanks for the suggestions.
Yeah, that's really powerful. I love that. Okay, this is a doozy. So in the last 1 minute, we can go like slightly over if need be. I wanted to address a comment that was made about really kind of the whole idea of intention versus impact, I think is what this person was getting at. The comment, and I'll just read it as it was in the Q&A so you know what it was. This is from Ed Koloff. He says, I understand the majority of the microaggression comments. However, as a spouse of an immigrant, I have tried to learn her language. I found it very difficult. So when I say your English is great to a non-native English speaker, I mean it as a compliment because I know how hard it can be to learn a second language. especially as an adult. I think this was, in response to some of the microaggressions that were shared earlier. So I wondered if you have any response to that.
That it is a valid comment, because it's extremely hard to speak another language. And, I give Ed all the credit for trying to speak his spouse's language, because it can be very hard. I think it all depends with the context in which the comment is given, because sometimes the comment is given in a way to downgrade that doctor. And you can notice the intentions, because I have people that told me that my English is good, and I don't consider it a microaggression, right? But it's usually the result of interactions. Oh, your English is so good. Where are you really from? Oh, you're brown. Latinas are spicy. So they usually come in clumps, right? And also, if the person doesn't feel comfortable, I have a microaggressions workshop that is available on YouTube, free to anyone. It's an hour long. Usually, if you don't feel comfortable, you can say, so what do you mean by that? And if the person comes from a place like Ed is coming from, the person will say, I just meaning there is a compliment. So this stops there. It's not considered a microaggression, and either of the sides gets affected. So context, intention is very important. And also, if you ask the other person, what do they mean? Because sometimes, the majority of the times, the aggressor doesn't know what is considered a microaggression. But honestly, before we end, I want you to know that microaggressions are like paper cuts. You can get a paper cut once a day, and you can survive. But for some of us, we get hundreds of paper cuts a day. And I pay the minority tax, I pay the gender tax, and I pay the age tax every day. So I come home and I have no money left for me, because I have been trying to justify myself over and over again why I have a place in medicine. So it may look like a little thing, but when you get 100 of them a day, it is very hard.
Yeah, thank you for that. And Phyllis Carr has a manuscript, I think that was published in Academic Medicine, that says a ton of feathers still weigh a ton, which I also find kind of evocative of that imagery, that people think, oh, it's just a microaggression, it's just a little feather, but ton of feathers still weigh a ton. I also want to share that, and so thank you for that response. I want to share that somebody posted in our chat that ACP has a webinar today at noon Pacific. I wish I had said something, learning to be an active bystander or upstander in the face of microaggression. So if you're feeling motivated and inspired, maybe capitalize on that and attend that. I don't know anything about it. I'm not endorsing, just sharing that that's happening later today in just a few hours. And Dr. Duma, there are other questions that I wish we had time to ask you, both in the chat, and I've gotten some private messages, but we'll have to, we're over time, so we'll have to stop it there. Thank you so much for your excellent presentation. And Dr. Harrington, did you want to add something?
I just wanted to get on and make sure I thank Dr. Duma. This was a fantastic medical grand rounds. We appreciate you spending time with us and with our community, so thank you.